Hello everyone and welcome back to Dr. Chen Hill's channel, a channel of everything from medicine to English. Last lesson, we did learn the structure and physiology of peritoneum, which play the background for peritonitis. Today, we continue the second part, symptoms of the peritonitis. Okay, let's start. First, there are several terms which are necessary to clarify because they are sometimes used indistinctly to define similar clinical stage. First, intra-abdominal infection. It is a broad term that encompasses a number of infectious processes, including peritonitis, diverticulitis, cholangitis, and pancreatitis. Peritonitis. Peritonitis is defined as an inflammatory process of the peritoneum. The serous membrane that line the abdominal cavity and the organs contained in that. Localized peritonitis is used when inflammation is in a limited area, such as adjacent to an inflamed appendix or diverticulum prior to rupture. This usually occurs when an inflammatory process in an abdominal organ extends to the serosal surface and then involves the adjacent parietal peritoneum. This is often seen in the context of acute appendicitis, a strangulation of a segment of small bowel, acute diverticulitis, or an abscess. In these settings, the clinical signs of localized peritonitis are very useful in implicating the underlying causes. Generalized peritonitis occurs when the whole peritoneal cavity becomes inflamed, for example, perforation of an abdominal organ, small bowel infarction. Intra-abdominal sepsis is severe peritonitis, brings about or results in a systematic presentation, shock, or organs function failure. Okay. Second, we will consider the division of peritonitis. If we look at it from the causes window, it will be primary and secondary peritonitis. The primary peritonitis is a rare cause of peritonitis resulting from an infectious process involving the peritoneal cavity. In the absence of an intra-abdominal source, it may be from the gut wall, the mesentery lymphatics, hematogenous, and translocate to the peritoneal cavity. Secondary peritonitis describes the peritoneal infections secondary to intra-abdominal lesions. It can be from gastrointestinal tract, biliary tract, pancreatic tract, or genitourinary tract. If we look at it from the agent's angle, it can be bacteria, virus, fungi, or chemical like acid, base, blood, or bile. If we look at it from the progress, it may be acute and chronic. Okay, third, we talk about the symptoms of peritonitis. Here, I divide it into three major parts: symptom of the system, abdomen, and investigation. The first one is about systematic symptoms. It including inflammatory syndrome. We can see fever, flushed skin and mucosa, and increasing in white blood cells and neutrophil. For dehydration syndrome, we can see sunken eyes and turquoise skin. For toxic syndrome, we see here. So the manifestation can range from none at all to mild and to severe. It can present in all organ systems such as the nervous system, respiratory, vascular, cardiac, renal, and hematogenous. For example, anxiety, dyspnea, rapid threat pulse, anemia, However, the clinical scenario can change dramatically from common, familiar to uncommon and extremely difficult to diagnose because of the background diseases. It also can change the manifestation due to the agents, the causes, and the stage of peritonitis. For instance, the toxic of symptoms due to fecal peritonitis is much more severe than tuberculosis and much more severe in late and general than in localized and early stage. The second major symptoms in here is abdominal presentation. I also want you to master two types of peritonitis here: localized and generalized peritonitis. We'll scrutiny on four main symptoms from abdominal pain, tenderness, abdominal warding, and rebound tenderness. For abdominal pain is now parietal pain and it localizes in one quadrant, but spread to more than two quadrants in the general type. The pain is sharp, well localized, and more severe than stage of visceral pain, but much more sharp and localized and severe in general one. For the tenderness, the character is in that module from one quadrant to more than two quadrants, and the patient might fling in your hand and hold their abdomen and curls. For abdominal warding, it also ranges from one quadrant to more than two quadrants, and from mild, clearly, to rigidity, both like and visible abdominal muscle. This pattern is also applied for rebound tenderness. However, you guys have to pay much more attention to the severe or late scenario with no sharp pain, no or mild tenderness, no abdominal warding, and no rebound tenderness. However, the patients may be in a prominent Tay-Sachs syndrome. Here, you guys may be asked about what's the value of these symptoms or what's more important. It's quite challenging to answer this question, so it's better for you to follow my IELTS guide for speaking part 1 with this WH question. So I would say, well, I have to say that it really depends on the scenario of the disease. For example, if there are full foment symptoms, I would choose the rebound tenderness because it is the only one representing for the parietal inflammation and not for other lesions as the others. Besides, I would tell you about some certain situations in which we couldn't find certain symptoms that I could tell you was more important. First, if we can contact with the patient to take the history, for example, in kids, mental illness, spinal cord injury, unconsciousness, or abdominal rigidity like bored, I would say the abdominal warding is the most important. Secondly, when we can't assess the abdominal warding, like in lax abdomen and in pregnant, the old flaccid paralysis, so I would say the rebound tenderness. Finally, when there are no symptoms, I would say they have no value for the diagnosis, but they can rely on paracentesis and investigation to diagnose. And of course, we have to reassess and follow the patient from time to time. See it? Have you seen the usefulness of learning IELTS? Yes? Okay. Now, we will consider other or accessory symptoms of peritonitis. For instance, abdominal distension, the bowel movement, and vomit. The symptoms you could meet at the late stage of peritonitis, or they are the symptoms of the diseases causing the peritonitis, such as bowel obstruction, gastrointestinal ulcer, or pancreatitis, etc. Or they just the coexisting diseases. Here I will tell you a little bit about rebound tenderness sign. Okay, this sign was described by Blumberg in 1970. He is a German surgeon. He wrote, rebound tenderness is performed by gradually increasing the pressure of the palpating hand over the tender spot and then removing abruptly. If the patient winces with pains upon withdrawal of the hand, the test is positive, indicating a likelihood of peritonitis. Okay, the sign I will show you how to examine in the appendicitis examination. You should notice how I examine it. For more, you can follow the link I write below to see how to make or how to perform this sign. Okay, in common situation, we could rely on the primary inconsistent position of the symptom to find the cause of peritonitis. For example, in epigastric region, we think of gastroduodenal perforation. In the right lower quadrant and hypogastric areas, we think of appendicitis and gynecology causes. In the left lower quadrant, we think about sigmoid perforation due to diverticulitis or cancer. In the right hypochondriac region, we think of the gallbladder source. And around the umbilical, we think of small bowel lesions. In left colic flexor, we think of colic lesion or the tail of pancreas. Next, we can rely on the characteristics of onset symptoms in related syndromes. For instance, a sudden severe constant pain and warding at the hypogastric is indicating the perforation of the gastrointestinal tract or the duodenal and the stomach. And we can rely on paracentesis or investigation to try more. However, the life is not always as smooth as the small path of Danville. For us to find the cause, here are several difficult situations or uncommon scenarios. Anatomical alteration, combining diseases, or we can't contact with the patient, in the children, the old, pregnant, or in autoimmune diseases. In this situation, we rely on all clinical and investigation data we have, and if we diagnose a general peritonitis, don't take time to find the cause. Just take laparoscopic or laparotomy to diagnose and treat the cause. Children, the old, and pregnant, we have to face in our life of the doctor. Okay, it's time to learn vocabulary. Intra-abdominal infection, localized peritonitis, generalized peritonitis, intra-abdominal sepsis, primary peritonitis, secondary peritonitis, spontaneous bacterial peritonitis, translocation, genitourinary, hematogenous, rheumatic diathesis. The Hippocratic phases of the terminal stage of peritonitis is well described since Hippocrates 460 years BC. Peritonitis was first recognized as a disease entity in 1802 by the young French surgeon Bichat, and then followed by the Lancet. Bichat insisted that in this condition, the pathology was in the peritoneum itself, in contradistinction to the commonly held view that all abdominal inflammations were infections of various organs. The possibility of an operative treatment now arose, but progress was soon stopped by an unfortunate instance in which the surgeon Dupuytren was persuaded to operate upon an appendicial abscess against his own judgment. The case died, which confirmed Dupuytren in his opinion that operation should not be done. Being the leading surgeon in France, the operative treatment was set back at least 30 years because of his influence.